Where the protection of the public is inconsistent with other interests sought to be promoted, the protection of the public shall be paramount. This meeting is unique, one of our first hybrid meetings conducted both in person and via WebEx. This meeting is also being webcast. Participants watching the webcast will only be able to observe the meeting. Anyone interested in participating in the meeting should attend in person with us in the room or join via WebEx meeting. Information and instructions are posted on our website. As I facilitate this meeting, I will announce when we are accepting public comment. I have advised the meeting moderator to allot 2 minutes to each individual providing comment. As appropriate times, we will begin to take public comments at the agendized location, which is 2720 Gateway Oaks Drive in Sacramento, followed by public comments for individuals participating via WebEx. This approach is necessary to facilitate this meeting, which again is the hybrid model. I appreciate everyone's understanding as we navigate this format. Before we get started, I'd like to ask the meeting moderator to provide general instructions on how to provide comments via WebEx. Moderator?
Good morning. This is the moderator. Before we get started, I would like to remind committee members and staff who are not speaking to mute their microphone during today's meeting. If background noise is detected as a result of unmuted microphones, I will mute those microphones. There are members of the public in the audience and meeting minutes are being taken, so we ask members and staff to please identify yourselves before speaking. For purposes of today's meeting, when Chairperson Serpa opens public comment, members of the public who would like to provide public comment at our DCA headquarters location in Sacramento can approach the table and microphone at the front of the room. For those joining us on WebEx, we will be utilizing the WebEx question and answer and hand raise features to facilitate public comment. When public comment is called, I will open the question and answer feature, which you will hear me refer to as the Q&A, and members of the public who wish to make a comment can click on the Q&A icon, type the word comment in the text box, and click on the send button. To utilize the hand features, simply click on the hand icon next to your name to raise and lower your hand. Those who have called into the meeting can dial *3 to raise and lower their hand. These instructions will be displayed on the screen during public comment. After we have taken public comment from our Sacramento location, I will call on those individuals requesting to comment through WebEx. Each individual will have 2 minutes to make their comments. I will provide a 10-second reminder when the allotted time is about to expire. At the conclusion of the 2 minutes, the individual's microphone will be muted, and I will move on to the next member of the public who has a comment.
Thank you. Before we begin, I would like to welcome to our committee our newest board member, Indira Cameron Banks. Welcome. There's a big round of applause. I will now like to take roll call to establish a quorum. Members, as I call your name, remember to turn on your microphone before speaking. Vice Chair Jig Patel.
Here.
Indira Cameron Banks.
Present.
Sung Oh.
Song O, licensing member, here.
Ricardo Sanchez.
Ricardo Sanchez, public member.
Debbie Veal.
Debbie Veal, licensing member here.
Thank you. A quorum has been established. As an announcement before we begin public comment, we will be deferring item number 6 on the agenda, FAQs regarding ADDS, to a future meeting pending discussion, so we will not be discussing item number 6 on the agenda. Thank you. The committee will now entertain any public comments for items not on the agenda. To facilitate this portion of the meeting, as I previously announced, I will provide members of the public that are present at the agendized meeting location in Sacramento to provide public comment first. This will be followed by any meeting moderator opening the, that's a mouthful. This will be followed by the meeting moderator, who will open the line for individuals who will provide public comment if they wish to do so, participating via WebEx. You are not required to identify yourself, but may do so. As we begin accepting this public comment, I'd like to remind everyone on the committee that we cannot take action on these items except to decide whether to place an item on a future agenda. Oh my goodness, I can hear myself. Members, following review of the public comments of this agenda item, I will survey, sorry about that, we're having a little bit of feedback here, so I will start again. Members, following the review of public comments for this agenda item, I will survey members to determine if any preference to items being placed on a future agenda. Apologize for the words up there. So we are open for public comment at the Sacramento location. Seeing none, let's go to WebEx. Moderator?
This is the moderator. I have opened up the Q&A panel on WebEx. Commenters in Sacramento can approach the table and microphone at the front of the room. On WebEx, locate the Q&A icon, type the word comment into the text box and click send. To utilize the hand raise feature, click on the hand icon next to your name, or for call-in users, dial *3.
So we'll go ahead and commence with WebEx. We have no public comment at the Sacramento location.
Thank you. And we do not have any requests for comments on WebEx. Would you like me to close the Q&A feature? Oh, actually, sorry, I take that back. We do have a request that just came in from Lori Walmsley. I apologize, I've mispronounced your last name. I will unmute you in just a moment, and you will have 2 minutes. You have been unmuted.
Chairwoman Serpa and board members, my name is Lori Walmsley on behalf of Walgreens. We respectfully request that the board either reconsider the definition of compounding in CCR 1735 or to create an exception within CCR 1735.8, compounding quality assurance for products that are made solely from commercially available, ready-to-use products, for example, Magic Mouthwash. The majority of our locations in California compound only this type of product and further only prepare about 4 to 6 prescriptions per year. The pending USP 795 updates, coupled with the current quality assurance testing requirements within CCR 1735.8, make it cost prohibitive for many pharmacies to continue participating in this type of compounding. We request that the board consider making a change to 1735 similar to that of Mississippi. Mississippi current regulation states that the combining of commercially manufactured ready-to-use products shall be exempt from 795 and other compounding standards under the following conditions. If no more than 4 commercially manufactured ready-to-use products have not been manipulated or used. We believe that this change would make these very simple compounds more available to the public and without sacrificing patient safety. Thank you for your consideration.
Thank you, Ms. Walmsley. And just to note, this committee will be discussing in-depth compounding in future meetings in regards to the implementation of USP standards. Other than that, are there any other public comments?
No additional requests for comments. Would you like me to close the Q&A feature?
Yes, thank you.
Thank you.
Members, hearing that this item will be on a future agenda, do you have any other comments?
Just to confirm, Chair Serpa, we are going to talk about commercially available products being possibly exempt from compounding in the future.
At our future meeting, when we talk about compounding, we're going to talk about compounding in length and in detail. Any other questions or concerns? Great. Moving on to agenda item 3, approval of the January 18th, 2022 committee meeting minutes. Members, included in attachment 1 is a draft of the January 18th minutes. Do you have any questions or comments on this draft? Part of your comments, I would entertain a motion for approval.
This is Song. I can make a motion to approve.
I'll second that.
Thank you. Moderator, we are ready for public comment. Again, we'll start with the Sacramento location. Seeing none, let's go to the WebEx.
This is the moderator. I've opened the Q&A panel WebEx. On WebEx, locate the Q&A icon, type a comment into the text field, and click send. To utilize the raise hand feature, click on the hand icon next to your name, or for calling users, dial *3. And we do not have any requests for comments on WebEx. Would you like me to close the Q&A feature?
Thank you. Now with the motion on the floor and public comment received, we will take a roll call vote. Vice Chair Jig Patel,
Yes.
Indira Cameron Banks,
Yes.
Sung Oh,
Yes.
Ricardo Sanchez,
Yes.
Debbie Veal,
Yes.
and the chair votes yes. Motion passes. Next item is item number 4, presentation, discussion, and consideration of hospital at home program. Members, this will be the committee's first opportunity to consider the hospital at home programs. These programs were established under a waiver by CMS that provides flexibility for certain health care services that can be provided outside of a traditional hospital setting and within a patient's home. As a part of the program requirements, patients can be only admitted into such a program from an emergency department, an inpatient hospital bed, or as an in-person physician evaluation is required prior to starting these services. Meeting materials included a link to CMS Hospital at Home Pharmacy FAQs. Most recently, in December of 2020, California Department of Public Health released an all facilities letter relating to the general acute care hospitals and its flexibility requirements for a hospital at home programs. The link to the AFL is also included in the meeting materials. A review of the California Department of Healthcare Services website reveals that only a few hospitals within California have received approval to operate these programs at this time. As a part of our education of this topic, we will receive a few presentations. First presentation is from the California Hospital Association. I'd like to introduce Pat Blaisdell, the Vice President of Policy with CHA. Ms. Blaisdell, are you there?
I am. Thank you.
Great, thank you.
Thanks very much for the opportunity to talk with you today. And I'm with the Hospital Association, and I'm excited to talk with you a little bit today about an overview of acute hospital care at home. This will be a very broad, very high-level overview of what the acute hospital care at home model is, a little bit about the current status in California, and then I know you're going to be hearing more from Kyle regarding some of the specific issues that they're seeing relating to pharmacy issues. So without further ado, I'd like to go ahead. If you could advance the slide, thank you. Again, hospital at home is an innovative care model that provides hospital-level care in a patient's home for individuals who need acute care but are stable enough to be safely monitored from their home setting or in their home setting. Next slide. I want to specify that hospital home is a unique and specific new service. It is a new configuration, a new component of the patient care continuum that we all work within. It is not the same as home health. It is not the same as case management. It is not the same as chronic care management, skilled nursing, remote monitoring, or admission prevention. All of these components, all of these services may or may not intersect with an acute hospital care at home model. As you will see, acute hospital care at home can help with things like chronic care management and admission prevention. Remote patient monitoring and case management are part of the package of services that a patient would receive and require under this model. But our current models in these areas, it's not exactly the same thing. So it is something that has received a lot of attention of late, and I'll talk a little bit about that as well, and for very good reason. So on to the next slide. A tiny bit of history. I know that my colleague Kyle is going to be giving you a little bit more background about how hospital at home services kind of evolved in other parts of the country. My presentation or my comments right now are going to focus on the CMS model, which is what we're most specifically involved with here in California. So during the COVID public health emergency, CMS observed that a hospital capacity was really becoming strained in certain parts of the country by COVID surges. And they were noting that some of these previous at-home hospital care models that had been operating in other parts of the country under commercial arrangements and so on had been successful. And again, I know that Kyle's going to give you a little bit more context about that. But given that they were seeing some good results and they were concerned about the need to minimize spread and maximize hospital capacity, they established the Acute Hospital Care at Home Waiver. That waiver was established in November of 2020. And they issued it as a provider-specific waiver. Now, at the beginning of the public health emergency, you might recall that they established the Hospital Without Walls waiver, which provided greater flexibility for hospitals to provide hospital services in other locations. So they could be doing some things in their outpatient department that they wouldn't normally do there, for example, to support social distancing. That's the same waiver that allowed them to have tents in the parking lot, or perhaps move patients around within their hospitals between one unit or another in ways that normally they wouldn't be able to do. So the Hospital Without Walls waiver was a big global blanket waiver. It included patients' homes to allow for telehealth and so on. But as things went on, CMS determined that they wanted more structure, more specificity around this particular model, acute hospital care at home model. So in November of 2020, as you learned earlier, they developed the Acute Hospital Care at Home Waiver, which requires a hospital to apply for a provider-specific waiver by demonstrating that they meet certain conditions. And I'll talk a little bit more about what those conditions are. This waiver is in place now, began again in November of 2020, and will continue through the end of the national public health emergency, which at this point we know will last at least until the middle of July of this year. So again, it is set to expire at the end of the public health emergency. Again, something I'll talk a little bit more about as we go on. Next slide, please. So if you want to get a hospital that's seeking to operate an acute hospital care at home must apply for a waiver. I think the link that was referenced before would bring you to the page within CMS. There's a fairly lengthy form a hospital would have to complete, a lot of attestations and answering questions about various service areas. Among those services, in order to qualify and get the federal waiver, you must have a specific patient selection criteria and an assessment process, including an initial physician evaluation in the admitting hospital. This was a little different than some of the previous models that had evolved in other parts of the country under commercial, in the commercial insurance space. But what CMS required is that this is a hospital-based program. The patient must be seen in the hospital, either in the ED or for an overnight stay, and have a direct assessment by the physician to determine before they are determined as an appropriate candidate for acute hospital care at home. So in order to get the federal waiver, a hospital must identify their patient selection criteria and their assessment process, which includes an assessment both of the patient's clinical status, clinical stability, as well as the home setting and whether the home setting is safe for that individual given their current medical condition. There must be daily MD assessment and RN assessment. There must be at least 2 in-person visits a day by RNs or paramedical personnel. There must be immediate on-demand remote audio connection to RN or MD. In other words, the patient at home and their caregiver should be able to immediately connect with a member of the medical team. They must be within 30 minutes of the ability to receive on-site urgent medical services, 911 level services. Each hospital must establish a local safety committee that is dedicated to the program to review certain data. The data that CMS has asked them to review regularly are things like the number of escalations, meaning bringing a patient back to the acute care hospital, the number of unexpected mortality, and so on. They also have to agree to submit regular reports to CMS. At one point, for new programs, they were having to submit those reports on a weekly basis. So those are sort of a very high-level overview of the very specific requirements. And if you go in and look at the application form, you can see that a hospital must attest to their ability and describe how they will meet each of these requirements. Next slide, please. Thank you. These are the services that a hospital at home must be able to provide at home and demonstrate how they're going to be able to do so in order to become an acute hospital care at home. Pharmacy, infusion, respiratory care, including oxygen delivery, diagnostics, monitoring with at least 2 cents of patient vitals daily, transportation, food services, including meal availability as needed, DME, physical therapy, occupational therapy, and speech-language pathology, and social work and care coordination. These are the menu of services that you must be able to provide either directly out of the hospital's operation or through a contracted arrangement in the patient's home as needed, consistent with the patient's medical condition, treatment plan, and goals of care. So just as an update, in California, we have had 7 hospitals or hospital systems apply for and receive the federal waiver. So if you go to the CMS website, you will see 7 different hospitals in California that have indicated an interest and a desire to provide this level of care and have met the conditions the CMS has put out. Next slide, please. As previously mentioned, at the state level, when the provider-specific waiver was implemented in November of 2020, CDPH came out with their state level. I should mention, of course, that CMS also says that any hospital at home must meet all applicable state licensing requirements. So when the provider-specific waiver was advanced by CMS, the California Department of Public Health issued AFL, the 2090, I believe, that specifies that in order to operate in California, a program must receive prior approval from CDPH, and in addition to meeting all of the CMS requirements, must apply for program flex approval for any regulation that they may need to develop an alternative mechanism to meet. So, and you can imagine, given the depth and specificity of Title 22, that's quite a few regulations. So the the program flex process is the current approval process that CDPH has established. We have, of those 7 hospitals I mentioned before, at least 3 have initiated a program flex referral process and are in the process of going back and forth with CDPH regarding their applications for program flex and approval of alternative means to meet the licensing regulations. One hospital has completed and received conditional approval from CDPH to operate. So we do have one hospital at home program operating in California right now. Now, I'm not going to be getting into pharmacy details in any great detail. I know that my colleague Kyle, we had a chance to connect yesterday from ASHP. He's going to be talking some more about what he's seeing in the pharmacy arena. But I will mention, next slide, please. Some of the things I've heard from our member hospitals are points of discussion for which they have had developed alternative ways of meeting the program flex requirements and are working with CDPH to develop appropriate program flex approaches. These are the areas that come up frequently in the discussions that those 3 hospitals have had or are having with the state. One is patient self-administration of medication. Sometimes medication, they will observe a patient self-administering it. But I know at least one hospital talked about how they developed a process for doing an on-site sort of competency and review to ensure that self-administration was being done correctly. Bedside storage of medication, and obviously the ability to manage and control the utilization of that medication. Monitoring of medication temperature has also come up as a request. And then also the stocking and restocking of a medication kit. The nurses that are visiting the patients at home and doing the on-site visits typically, in most of these instances, have some kind of medication kit. And so the hospitals have developed kind of a check-out, check-in process to ensure that the supplies, there's control of the supplies. Again, I know in the subsequent discussion, you'll hear more about some of the ways some of these issues may be addressed in other areas. Next slide, please. I did want to spend a minute on one of the reasons why acute hospital care at home is getting so much attention. We are finding that the outcomes are quite good for the right kind of patient. Again, this is not for everybody. Patient needs to meet certain clinical stability issues and be able to receive the care safely and effectively at home. But many of the studies out there are showing some very promising and encouraging results for improving health outcomes. I should mention that a lot of this data predates the CMS model, the acute hospital care at home model, because that came into view, just a little over a year ago. I do have some CMS data I'll share in a moment. But these are some of the reasons I think that gave rise to CMS's interest in continuing to look at this program. We are seeing that in most hospital readmission, hospital at home programs, both pre and during the acute hospital care at home waiver period, that they have favorable comparison to hospital-based services in hospital readmission rates, ED visits, and the need for subsequent admission to a skilled nursing facility. So it appears that for certain patients, acute hospital care at home can reduce unnecessary hospital readmissions, ED visits, or admissions to a SNF. Patient satisfaction is consistently much higher. They prefer being at home. There's some data to indicate reduced rates of depression and anxiety, both during and subsequent to the acute hospital stay. And an area that I'm particularly interested in is for older adults. They're seeing significant, and some of the studies are identifying the potential to reduce significant onset of some of the disabilities we see that are associated with routine hospital admissions. We all know that older adults that are admitted to the hospital often suffer the onset of new disability, functional decline, or delirium, and we're seeing that acute hospital care at home can potentially minimize these effects. I've included a few references here. There's actually quite a few more out there, but just to kind of give you an idea of some of the discussion and review that's going on about the value of hospital home and for which patients it might be particularly helpful. Next slide, please. As I mentioned, the acute hospital care at home waiver, the one that CMS put some structure on, has really been in existence only for a little over a year now. So the data that's coming from that is relatively small. But this information from the first year of the acute hospital care at home waiver shows that they reviewed the number of escalations. Now, an escalation is where within the expected acute hospital stay, the patient has to go back to the hospital. So a patient who might normally have been in the acute care bed for, let's say, 5 days, maybe they're in the hospital just 1 day and then go home under hospital at home. If they have to go back during that 5-day period, that would be considered an escalation. So they're still under acute care at home, but they end up having to go back to the hospital. So that's an escalation. CMS notes that the rate that they're seeing in the initial experience with acute hospital care at home compares favorably with what they've seen in the non-CMS based hospital at home programs. And in terms of reviewing the mortalities, they also have reviewed every unexpected mortality. Specifically, I won't go into all the details, but they noted that in 3 of these cases, the patients died of consequences of COVID-19. Many of the cases, most of the cases had been able to go back to the hospital and receive intensive care prior to their expiring. So again, the preliminary information from CMS is that, at least on these very broad and kind of blunt measures, they're identifying that they see potential going forward. So current status, next slide, please. I'm not going to go into a lot of the policy issues, although as a policy wonk, that's one of my favorite things to talk about. But just to let you know where the current status is, the waiver, as I mentioned, is slated to expire at the end of the public health emergency, whenever that might be. However, federal legislation has been introduced that would provide a 2-year extension of the current CMS waiver. The idea of getting the extension would be that it would allow CMS to continue to establish these provider waivers, monitor the outcomes, and look at the potential for creating this program on a more permanent basis. One of the options might be for them to look at doing a demonstration program under the CMMI, the Centers for Medicare or Medicaid Innovation. Regardless, there is a fairly broad coalition. You may have seen things in the news, Mayo Clinic, Kaiser Permanente, and so on, that have worked together to advocate for this legislation at the federal level. American Hospital Association is also in support. At the state level, if that extension happens, contingent upon that extension happening at the federal level, we have introduced legislation that would provide for a state level process to align with that provision. And continue to provide for appropriate oversight. Again, this is not the time or place for us to get into the details of that, but did want to let you know that there's a fair amount of discussion around this issue at both the state and federal policy levels. That concludes my remarks, and I know that we're going to go into and hear some greater detail, in particular around pharmacy-related issues, which I know is your primary focus, from Kyle. And I can respond to questions. I think it would be best for us to wait till after Kyle's presentation, perhaps, to do that if everyone's in agreement.
Thanks, Ms. Blaisdell. Let me check with our attorney. I think we're slated to take comments now.
Oh,
Can we
okay, that's
postpone
fine.
that as
I
she
can
requests?
do that.
I think you can do it however you want, but if you might want to give people some additional comment time if we're talking about 2 presentations, depending on what they're doing, or
Okay.
cover both of them at the same time.
Okay, let's ask members if they have any questions or comments for Ms. Blaisdell. Thank you for your presentation. And as you request, we'll do additional comments for after Dr. Rob's presentation. Thank you. Let's welcome Dr. Kyle Robb, State Policy and Advocacy Associate with the American Society of Health System Pharmacists. Dr. Robb, can you hear us? Are you there?
Yes. Good morning, Chair Serpa and members of the committee. Thank you for having me.
You're kind of muffled. Can we improve his sound in some way?
How about now?
Technical moderator, can you help us with the sound?
This is the moderator. Kyle, I would imagine you're as close as possible to the microphone.
Yes. Do I sound better now?
Yes.
Okay. Sorry for that little snafu. And my next challenge is going to be trying to share my screen. So let's see how this goes. Is everybody able to see my slides currently?
Dr. Robb, the floor is yours.
Thank you. And I assume everyone's able to see the slides.
Yes, we have your slides displayed. Thank
Okay.
you.
So again, thank you to Chair Serpa and the members of the committee for having me here today. I am, as mentioned, the State Policy and Advocacy Associate at ASHP, so I really run the primary point on state policy issues for ASHP, and here today to present on hospital at home considerations. First, Pat did a great job of getting into some of the drivers of hospital at home, but I just wanted to share this infographic as well. There are a lot of potential for future development of hospital at home programs. Particularly, the CMS waiver was developed in response to a hospital bed shortage and capacity issues related to the COVID-19 pandemic, but also there are potentials for new care models and different ways of workforce management and healthcare delivery. Payers may prefer advanced acute care in the home. It could potentially be more cost efficient than a lot of current hospital-based care. And consumer preferences may drive a move of care to the home, as people prefer to be treated in the comfort of their home rather than having to be admitted to a hospital. By way of a little bit of a background, the concept of hospital at home was originally developed at Johns Hopkins University in the mid-1990s, and initial trials of various hospital at home models were conducted in the late 90s and early 2000s. These did find consistently that when implemented in the correct patient populations and with the correct controls, it was feasible, safe, and cost-effective to deliver some of these acute care services within the home. In these surveys and pilot studies also consistently found that there were shorter average stays, there were lower overall cost of care, and higher patient satisfaction. This infographic comes from David Levine. Dr. Levine is a thought leader in hospital at home and currently an administrator at the Brigham and Women's Hospital and Harvard Medical School, and has overseen several pilot programs in hospital at home for them. This just shows some of their trial outcomes for hospital at home. They found that they, on average, ordered less labs and less imaging. Excuse me, I apologize. And also the patients were in bed less often. They showed improved physical activity. There were a lower overall cost, and there was unchanged metrics in safety and quality of care, with 0 patients in these specific trials transferred back to the hospital. Fast forward to the 2000s, we saw veteran affairs hospitals in several states launch hospital at home programs, which they are still maintaining today in 5 different states. In the late 2000s and early 2010s, with the development of audio video technology, we saw a transition of the hospital at home care model to having the physician consults primarily occur via audio video telehealth consult. So in the early iterations of hospital at home in the 1990s, physician consults would happen by home visits. In the more recent models, including the CMS model, after the initial physician consultation, oftentimes physician consultations will occur purely via audio video platform, and nursing and vital assessments will be taken in person. But if a patient's course is going as expected, the physician consults will most likely be exclusively via audio video platform. In 2015, the CMMI began issuing grants to test the hospital at home model in the Medicare program. And to just give a brief sort of patient experience and sort of how the hospital at home process works, is the patient is first identified as a candidate based on their clinical status and their diagnosis, either in an emergency room or an inpatient hospital department. Academically, there are models presented in which outpatients could be admitted from an ambulatory site or a clinic directly into a hospital at home program. As Pat mentioned, the Medicare waiver only allows for admission via the emergency department or an inpatient hospital bed. The patient has to consent to hospital at home. So again, all hospital at home programs currently are entirely voluntary. The patient has to consent and want to be treated in the home as opposed to in a hospital. They then receive medical transport to their home because again, they are in that to be considered as a hospitalized patient. So you would give hospitalized patients medical transport. There's often more acute or intense care and monitoring in the initial portion of admission, and then as needed, that that in-person monitoring and in-person assessment can decline to the 2 daily visits that are currently required by the Medicare program. Again, you will receive the patients will receive a daily physician evaluation and assessment, but that's often done via telehealth platforms. Patient selection and eligibility criteria are really key to the success of hospital at home models. So you're really looking for patients who are most likely to only need diagnostics and therapies that can be practically delivered in their home and are at lower risk for worsening of condition and escalation requiring hospitalization in the hub hospital. If the patient does require any brief visits for diagnostics and therapeutics that are not available in their home, they would be transported to a medical facility via medical transport for their services. Again, that would not be ideal though, so you would be looking to select patients who are least likely to require any transport out of their home. The patient is treated by the hospital home care team until they are discharged. So just like in an inpatient setting, the hospital team provides all care to the patient until the discharge occurs, at which point care for the patient reverts to primary care, just like in a typical hospitalization. Pat mentioned the launch of the Hospitals Without Walls programs and the impetus to launch the Acute Hospital Care at Home program in November 2020. The CMS Acute Hospital Care at Home program for Medicare currently extends to over 60 acute conditions and diagnosis-related groups. Most common among those we see treated in hospital at home are heart failure, pneumonia, COPD exacerbation, and soft tissue infections. As mentioned in the Medicare program, the patients have to be admitted directly from the emergency department or an existing inpatient hospital bed. An in-person evaluation is required prior to any referral or initiation of at-home care. There are a minimum of 2 in-person vital assessment visits daily. And as of April 2022, we have 93 health systems and 210 hospitals in 34 states that have been approved for participation in the waiver. But again, as Pat mentioned, not necessarily all of those hospitals are actually currently treating patients via a hospital at home model, as they sort of still work to implement those based on local regulations or other considerations. I did want to point out that we also included for the committee's consideration in the meetings today a copy of our recent report on hospital at home and alternative sites of care. In November 2021, we brought around thought leaders and hospital pharmacy executives from around the country to discuss implementation of programs and perceived barriers to implementation and experiences of executives who work in hospitals who already have implemented these programs. So that can provide some additional insight into considerations that need to be taken. And a lot of my subsequent slides are taken, summarized from that report. So this infographic really summarizes the main considerations that were pointed out during that conference. Really, as I mentioned, patient selection, eligibility criteria, and triage are most vital, perhaps, component to success of any hospital at home program. After that, pharmacy, the main consideration is how are you going to handle the medications? That both extends to self-administered medications and non-self-administered medications. Most often those are infusions. How are you going to integrate your technology and electronic health record? So the patient's health data is transmitted into the medical record and accessible in the same manner as it would be for a typical hospitalized inpatient patient. How are you going to manage storage and waste of medications in the home? How are you going to organize your workforce? So that includes both what staff are you going to send into the home, how frequently, and how are you going to organize the digital command center back at the hub hospital that will be responsible for the continuous monitoring of the patient during their hospital at home stay. Again, how do you get the patient access to the exact same suite of clinical services within their home that they would have in the hospital, which is the goal of hospital at home? And how do you maintain compliance with legal and regulatory requirements, though we will not get into the billing aspects of it during this meeting. So main considerations for pharmacy, again, it's essential to make sure you have full integration of patient access to all clinical pharmacy services, and that you have a medication distribution model that retains the provider's authority over the medication use process. So you are in the patient's home, but for the Medicare waiver program, they are to be considered as an inpatient hospital patient. So you would not allow a patient in the hospital to completely manage their own medications. You do need to have tight control over documentation of the medication administration record and the ordering and dispensing of medications to the patient throughout the duration of their hospitalization. And again, how are you going to integrate all of this into the EHR and make sure that all the data you are getting and receiving is fully interoperable? So the next stage, I just posed some of the key questions that came up during the conference for consideration of people who are involved in hospital at home care programs. What is the quantity and ideal timing for delivery of medications, and who are providing them? So are these medications coming from the inpatient hospital pharmacy as they would for hospitalized patients? Whether or not that is allowable often comes down to state law, whether state law would allow for the delivery of these medications from the inpatient hospital pharmacy to the patient's home. If not, or if not practical, are you delivering the medications from the hospital's outpatient pharmacy? If you don't have an outpatient pharmacy or the outpatient pharmacy has limited hours, are you partnering with a community pharmacy or a retail pharmacy to deliver some of these medications? When the medications are in the home, how are they handled? How do you go account for auditing and ensuring there are not any missing medications? And what emergency medications must be available? If a patient is in the hospital, hospitals in the main pharmacy keep a complete code card available at all times. It's probably not necessary to have a complete code card in every single patient's home that is in a hospital at home program, but at the same time, there are probably emergency medications that must be available to the patient. So how do you define what those are? How do you make them available to the patient if needed? How are medications, including controlled substance, properly stored and secured in the home setting? Again, in the inpatient environment, we often have a separate locked medication storage room. It is not practical to have a separate and locked room in the patient's home, but at the same time, there is a need to secure the medications. So, how are you going to go about establishing procedures to make sure they are secured? How do you go about wasting drug that is unused within the patient's home, especially if it's a hazardous drug such as chemotherapy? At the end of the hospitalization, how will discontinued or unused medications be handled or discarded? Will they all be discarded at the end of the hospitalization? Will you attempt to set out a sort of a chain of custody that may allow for some recovery of those some medications, or are they all discarded in whole? And again, the IT component of this is extremely essential. You don't want a situation where you're documenting everything in paper and then manually transcribing it. So you really need full integration into the EHR. How are you documenting the administration of medications? So a lot of programs we've talked to have audio-visual technology. So again, it's a requirement that the patient be able to reach the care team remotely at any time. So they have that button to call the care team. Lots of times we've seen the development of technology where when they hit that care team button, they are being recorded and they're asked to record themselves every time they take medication so it can be properly documented in the medication administration record. And then the question of patients' access to internet. Is the hospital going to be supplying the broadband capabilities necessary to run all of these remote technologies? Or are we going to have to, at least in the near term, limit these services to people who have adequate data bandwidth? As mentioned in Pat's presentation too as well, it's extremely important that we have a process in place to make sure that patients understand how to use their medications, and we validate that they are highly likely to take their medications as scheduled and capable of taking their medications as scheduled. And then the question of who is going to complete a medication reconciliation and take a medication history. It's obviously prudent to do that at the point of admission and evaluation and when the patient arrives in their home. But the question is who will do it? Is it going to be a pharmacist? Is it going to be a nurse? Is it going to be a pharmacy technician? And how often will auditing of medication administration and the patient's medication record occur throughout the hospital at home? Again, how is medication management going to be done? How do we account for as needed medications? How do we account for changes that may need to be made to the medication regimen and making sure those can happen quickly and nimbly? And how will we provide 24/7 pharmacy coverage if the pharmacy providing the medications, again, from the hospital is not open 24/7? How are you going to arrange for that support to be available 24/7? Future considerations that our group pointed out that to inform the development of future guidelines is that it is essential to include pharmacists in the planning and implementation of these programs. It may be necessary in the future to develop a legislative and regulatory framework that is specific to safe and effective medication use in the hospital at home setting. And we will need to continue development of education, training, and resources to educate the pharmacy workforce and really the healthcare workforce in general on proper care of hospital at home patients and continuing additional research on hospital at home care models. Thus concludes my prepared comments. So I will cease sharing my screen and open it up to members of the committee for question and answer. Thank you.
Thank you, Dr. Rob. I appreciate your time and efforts for educating us. I also like to recognize a member of our audience, Dr. Chen, also from ASHP, who's in the audience listening in. Members, do you have any questions for Dr. Rob? Go ahead, Ms. Veal.
Yes, Dr. Rob, have other state boards of pharmacy addressed this issue? And, you know, do you have any comments on how they have addressed it and what, you know, how they're tackling it?
So I have had discussions with members of other boards about hospital at home and inquired to how they're going about regulating it. And the anecdotal responses that I received were that hospital administrators were contacting the board and asking the board sort of for guidance. But the board, the members in the two states that I spoke to, both sort of indicated a hesitance that they didn't want to be too prescriptive and promulgate regulations too soon because they didn't want to discourage the sort of continued development of these programs. In the meantime, they sort of, encouraged these hospitals that were implementing these programs to make sure that they are complying with the labeling requirements for outpatient prescriptions and sort of they can be informed based on existing home infusion regulations. So really looking at like a hybrid between the regulations that apply to inpatient patients, to outpatient patients, and to home infusion patients, and trying to maintain compliance between those three things. But none of the boards that I've spoken to have felt it necessary to have a comprehensive set of regulatory guidelines on hospital at home at the moment. We are still, we have to acknowledge we're all still very early in this, and there are a limited number of patients currently being treated.
So I'm assuming we're talking about this because probably our council has said that we might need to make some changes to our current regulation.
Yeah, I have some comments to make.
Okay.
As soon as we go through the board of having additional questions. Maybe I should make my comments first and then you could ask questions. Would that be preferred? Okay. So just to kind of summarize for Ms. Blaisdell and Dr. Rob's presentations, great presentations as some background material for us to consider as a board. I think just to share my thoughts and how the board may move forward is this is a great advance to make medical services available to patients and members of the public. But there are some concerns that the Board of Pharmacy needs to monitor and address. And so that's what we're here to consider is what areas of concern do we have? And first of all, I see that there are some patient safety things that we need to really make sure are appropriate. And those would be a review of the types of medications that are in the first dose kits, what's appropriate and what's safe to be out in a first dose kit or to be readily administered by the patient themselves or a nurse, keeping in mind that those medications in the first dose kits would be administered in advance of a pharmacist review and verification. So that's something for the board to consider is these medications that are given prior to a pharmacist review. There's also what they both talked about was the security and safety issues, security and storage issues of the medications, not just in the patient's home, but also in the transportation. In the nurse's car, for example, is it 110 degrees? And those kinds of things we'd have to consider. We'd also need to talk about controlled substance security and those concerns. It appears that those places that are using the hospital at home system have bypassed the concerns of controlled substances by not having them as part of first dose kits or part of the medications provided by the hospital at home program, but as a prescription that is provided by an outpatient pharmacy and the patient's property as controlled substances. That's something that we could talk about. And then lastly is really to assure that we have the documentation issues that Dr. Rob mentioned, how to document patients being administered medications, and are they being administered safely and monitored? An example was one of the documents that we received was an example of first dose kits, including IV medications that may require additional monitoring, like EKG monitoring, blood pressure monitoring, those kinds of things. I think we have some opportunity to discuss to assure patient safety. So that's kind of a brief overview of my comments, but I'd like to open up for the rest of the board. Any questions or comments?
So, and I'm just going to go for the very first thing you said, and that's the kit that goes home. So I'm thinking like.
Sorry, it's not the kit that goes home. It's the kit that's with the nurse.
Okay. I'm thinking of that being similar to like the emergency kits, like in long-term care. Do we regulate those? I'm thinking we don't, I guess.
The board at this point does not, I think they're regulated by CDPH.
The skilled nursing facility?
Yeah.
What's the contents of the emergency kits? Are CDPH and CMS regulated?
Because I guess what my point is maybe we need to determine, I think that's a good point, but we maybe
What's
need
our-
to determine, and it's, to Dr. Rob's point too, what do we, I think we could cause a problem if we overregulate. So we need to kind of look at like, that should be a concern, but let's not overregulate something that causes, because it sounds like a great opportunity in certain cases. And I mean, I think we've all had family members in the hospital, and it's miserable being in the hospital sometimes because they're in there checking you all night long. It would be so much more comfortable and less stressful to be at home. So I could see this being a very positive thing. So I just want to make sure whatever we do, we don't get in the way, basically.
Thank you. Any other member comments?
Yeah, I wanted to say along the line that currently closed door facilities provide these prescription e-kits to skilled nursing facility. This program kind of mimics and has more than skilled nursing facility. So there are labeling requirements and record keeping requirements for e-kits, et cetera, that are already in place, I believe, Eileen. And if we keep it as is, then they can operate within the current medical board requirement on how they are operating the hospital, and it will streamline the process.
So those are areas that we'd have to review, and as we learn more about this program, review and assure that it's there, because it is a different license category. An acute care pharmacy may be the provider of medications, where if it's a long-term care pharmacy that's providing the medications, then those regulations exist. We just have to make sure that the process is consistent and safe. But I think there's opportunity for us to further discuss and get into the details as we learn more about this program. Any other?
Because we might already have solutions. And that's
We
a
may.
great point, Jig, is that maybe we kind of align it more with the long-term care, because I think they even have, regulations about how you keep track of, dispensing and all that kind of stuff. So.
Yeah, and the whole consultant pharmacist visitation requirements, et cetera, and could be slightly modified for acute care pharmacy, and like you said, we can stay out of the way and continue to have this process.
I think, if we stay in our lane, like Ms. Veal was saying, stay in our lane for what is the Board of Pharmacy. There are a lot of the steps that are regulated already by CDPH that requires pharmacist review of orders and pharmacist involvement more than just monthly. So, these would probably be more similar to the acute care standards with the California Department of Public Health. Okay, let's move on to public comment. Do we have any public comment in the Sacramento location?
Good morning, Mark Johnson with CVS Health, but these comments are more along the lines when I was the executive director of the Idaho board. We went into great detail, about 10 years ago and allowed hospice nurse e-kits. We listed the drugs that could be contained within the e-kit, which was vastly outdated, and every year thereafter we went in and added to the list. We forgot glucagon the first time around, and eventually we got rid of the list and we just trusted the nurses. And then in the long run, we got rid of the rule and just really trust the nurses and had basically no regulation of it, just allowing the practice. And I'm not aware of a single public safety issue that's ever arisen, diversion or anything thereof. Maybe would check with Nikki if it's appropriate, the executive director of the Idaho board, to see if there's any kind of issues that I'm not aware of, not being the exec anymore. But I basically wanted to say we did overregulate it for really no reason and backed off. Thank you.
Thank you. There's no more comment at the Sacramento location, so we will open up for WebEx comments.
Moderator, I've opened up the Q&A panel on WebEx. The instructions will be on your screen shortly. Commenters on WebEx, locate the Q&A icon and type comment into the text box and click send. To utilize the raise hand feature, click on the hand icon next to your name, or for call-in users, dial *3. And we do not have any requests for comments on WebEx. Would you like me to close the Q&A?
Yes, thank you. Again, thank you to Ms. Blaisdell and Dr. Robb for your comments and for your presentations. Very informative. Members, I'm aware that the Legislation and Regulation Committee is reviewing the pending legislation in this area. I think that the information we've learned today will help shape the board's actions considering this legislation. At this time, I believe that though no further action is appropriate, it's premature until we understand the board's policies specific to these programs. If these programs continue to operate beyond the emergency date, I believe it's important for us to consider how pharmacy-related care is provided to this type of patient care model to ensure patients receive appropriate care. Members, any final comments?
So just a clarification, you said our policies about this. I mean, do we need to create maybe kind of a open policy of, where we are, or are you saying that we don't create any kind of policy, we just wait and see what happens in the legislature and then come back?
I think the situation is fluid. There's, it's maybe a bit early to have official policies. This is something that we can consider through the Legislation and Regulation Committee. Also, there's the potential that this could go on pause when the waiver is expired unless legislation passes. So we do have time to consider all the issues. So at this time, I think it's a little early to have a formal policy.
Well, I guess what I was thinking as far as a policy is, do we at least want to make some sort of a statement that we're in support of this type of care and, look forward to, I'm not sure exactly what more you put in there, but it just seems like this is like the future. Mm-hmm. And, maybe we at least have a statement that we're in support of this type of care and look at, I don't know, maybe it's not as.
I'm looked more to Ann and to Eileen because I think currently our policy is about patient safety and patient access, and may cover that until we have more information regarding
this. Is definitely patient access.
Yeah. So Ann and Eileen, your thoughts? Does our current strategic plan cover what our policy is for access and safety?
I think it does, but I'd also talk with Ann, but it might be premature, as Dr. Serpa stated, because if this currently it's operating pursuant to a federal waiver, for the declared emergency, kind of like a lot of our waivers. But it's good to get maybe on the agenda, because I think as we hear more what this project, it's been in process for just 1 year. It sounds like maybe they don't have the data. We might get more data out, but I would defer that to the board if you want to do something. But I think the board's been on point with supporting different efforts during this public health emergency, without getting unduly in the way of our public health officials from responding to that crisis. But I would defer it to this committee and the board, whether you want to make a further policy statement at this time.
So I think as it's pretty routine for the board to establish a position on pending legislation. And because there is that legislation, I believe that the board, through its potential establishment of a position on that pending legislation, could be conveying some of its policy through the position.
Thank you.
Okay, thank you. I just want to make sure that we sound, I mean, I know it's been a year for the waiver, but it sounds like it's been around more than that. And so I just want to make sure that we are forward looking and not just reacting.
Thank you. Any other comments from the board members? Moving on to item number 4, discussion and consideration of compounding by board licensees outside of a pharmacy. Members, meeting materials provide some relevant sections of pharmacy law. We have, as members, received comments about pharmacy personnel compounding outside of licensed pharmacies. And it is my understanding that board staff have observed this practice as well. This is the first time that we have discussed this as a committee. As indicated in the meeting materials, staff are familiar with some investigations and patient care issues that have been identified regarding some compounding practices in some locations. Members, I draw your attention to the chair report, the committee report, for the specifics of the concerns, and I'll address them also in my comments. But do you have any comments at this point? Do you want me to start?
I do.
Okay.
Go ahead.
Go ahead.
Ricardo.
Just with some of the investigations on the patients that have been identified past. You could, I don't know,
So,
elaborate on some.
okay, or Debbie, did you want to talk, or do you want me to start off
Well,
with the background?
I just want to kind of throw out there, just because I'm on licensing committee, and we actually talked a little bit, not specifically about this yesterday, but some of the bullet points in the material is a board licensed technician ordering drugs in under a physician's license, but they're practicing not in a pharmacy. So does it really matter whether they're board licensed technicians?
So maybe I'll give my background material first so that you can kind of understand.
And this is what we said yesterday, because yesterday we had the comment that they're not.
So my areas of concern are really those 4 bullet points that are on page 3 of our committee report,
Right,
but they're really
all
in
the
3 areas. So the first 2 are very similar, to bring to your point, Ms. Veal, is that we have pharmacy technicians practicing without a pharmacist in some non-pharmacy locations. And that action is not the issue, because the action could be done under a medication assistant, for example. But the term and the title and the name tag say pharmacy technician. That's my concern. It's not the actions, but that there are pharmacy technicians who are being hired as pharmacy technicians to practice without a pharmacist present and outside of a licensed pharmacy. That's the first one. The second one is you have pharmacy technicians practicing with a pharmacist outside of a pharmacy location. This is currently authorized under waiver for mass vaccination sites, and that's the only place where a pharmacy technician can practice outside of a pharmacy without a pharmacist present, is on our current waiver for mass vaccination sites. That's the second one. The third one is very broad, because it's something that we had quite a few examples of, and that's where we have pharmacists who are practicing outside of a licensed pharmacy, which is appropriate and legal to a certain extent. We have, and some examples are, we have pharmacists who are practicing and preparing compounded medications outside of a licensed pharmacy, but maybe in a licensed clinic or a physician's office. and they are practicing under lesser standards than a standard pharmacy. My example is pharmacists in this situation feel that they don't necessarily need to follow all the sterile compounding documentation and laws because they are not practicing in a pharmacy. Our concern is, as a pharmacist, they are required to practice under the required regulations of a pharmacist, whether they're in a pharmacy or outside of a pharmacy, and that's not what the current practice is. So those are the three major bullet points I think that we could discuss a little bit more. Some of it is education, but some of it is also potential regulatory concerns for the future.
So I think the question is, how can we, and I agree, those are deep concerns, how can we make sure the licensees, non-pharmacy license, who are blatantly practicing pharmacy without pharmacy license, that kind of are not in our regulatory purview, but maybe they should be in our regulatory purview. So how can we make that happen? Is that a legislative proposal? Do we have to have some legislative proposal for us to actually get in there to regulate those businesses? And I think that's the question we have here. So-
Well, actually, looking at the agenda item itself, it's all about board licensees. And so we're not really have on the agenda to discuss non-licensed activities. So what we're talking about now is compounding activities that are happening by board licensees outside of a pharmacy. So these are our licensees. These are all pharmacy technicians and pharmacists.
And
Except we don't really have, I'm sorry. We really don't have jurisdiction over a technician. And I understand your point, she has that label on, but she's, or he, the first two bullet points, I don't think we have jurisdiction over those people.
I think that's an educational item. My preference would be that we use that as an educational item to educate pharmacy technicians that they only use the title pharmacy technician when they're working under a pharmacist. Otherwise, they should have a different title.
Okay, but is that solving what the problem is?
No, because it's not, okay. That's my opinion.
it's-
So,
Yeah, I mean,
I want to hear what the board says, sorry.
it's a loophole
yeah,
and it's a patient safety issue
exactly.
where, simple things like hormone replacement or, whatever compounding they're doing, derma practices, where they're making these compounds, they are not following any board of pharmacy guidelines, and it's been provided to consumer. And that's a big deal. So how do we combat that loophole that's currently there? If it's not in our jurisdiction, does it fall under medical board?
So I think we're going beyond the scope of the agenda item because the agenda item is regarding pharmacy technicians. Currently, they can hire medical assistants to provide those functions, and that's beyond the scope of this board.
Actually, I'm looking,
But
it says
outside, yeah, exactly. That.
by board license outside the pharmacy.
So I feel like it covers, yeah.
Eileen, can you help us? Am I incorrect, or is this in scope or out of scope?
I think it's in scope. We're trying to get a idea
Because-
of what the issue is, and this did come up at licensing committee.
Because-
yesterday, like on a peripheral.
Doctors' offices are not licensed, right?
Correct.
So obviously, doctors' offices, compounding at doctors' offices might, blatantly without being licensed, and mass compounding. That's a loophole that I think we need to, it's
I think we need to parse it out because I think doctors do have the ability to compound.
right. They do.
And
so
so
the
I think
fact-
that's why I was trying to explain that we wanted to really talk about just pharmacy technicians because there are practice settings where they're allowed to compound. Doctors' offices, veterinary clinics, and maybe one other, I can't think of it right now. Those are not under the purview of the Board of Pharmacy. What I'm hearing is that you would like to discuss that issue, but that's not currently under the purview of the Board of Pharmacy.
But, I see what you're saying, Dr. Serber, but part of it is kind of connected because, for instance, there is no provision of law that I'm aware of that prohibits somebody else from hiring somebody who's got a pharmacy technician license.
But
and
the
so
pharmacy
there's- So, for instance, if a doctor's office could hire a PA, a physician's assistant to help with compounding, could they hire somebody that has a pharmacy technician license. There isn't anything that I've seen in the law. There are some other things under federal law. For instance, certain licenses you can only obtain if you need to use them, like in the securities field, because it has to be maintained by the firm. So I think what we might have to do, and I understand the concern to keep it narrowed, but is to look at whether or not there are current laws that would prohibit them from advertising the fact that they're a pharmacy technician.
Well, what I understand from previous legal opinion, so this may be incorrect, because it's my understanding, is that there is nothing to keep providers from hiring pharmacy technicians to work in their practice, but they are not licensed pharmacy technicians in that activity. It'd be no difference than me hiring a physician to be a nurse and then having that nurse act as a physician. They can't do that. They'd be hired as a nurse and they have a physician license, but they're still a nurse in my practice. So that's the difference, is that they could hire a pharmacy technician, but they would not be titled as a pharmacy technician or regulated as a pharmacy technician. Am I not stating?
That's right. I don't think that your interpretation, and maybe it's.
Okay.
So Eileen,
Because, I mean, if I'm a pharmacist and I work at McDonald's, I'm still a pharmacist.
But you're not distributing drugs at McDonald's.
so Eileen, if a technician,
But that doesn't mean, I mean, I just don't, go ahead.
if a technician is working at a physician's office, whatever, whatnot, whenever they're compounding, they're not using license, they're using their skills, right? So they work for the physician, and physicians are allowed to have someone compound, I would assume. And that person, what kind of requirement is there? Is that fall under medical board
It would
regulation?
fall under medical board. I think they could hire some other people, but I think what you're saying is right. The way the current law that I read, and we'd have to look at each facility, is we don't, so for instance, if somebody is compounding in a doctor's office, would they have to be a pharmacy technician? No, because it's outside of a pharmacy. I don't see any prohibition that says that somebody, can't use their pharmacy technician abilities outside of a pharmacy. Whether or not they should be labeling themselves as a pharmacy tech is a different type of issue. But like, for instance, for the medical board, if they're going to hire somebody, or a practice is going to hire somebody to help compound it, they might want to hire somebody who's a pharmacy technician, who's got the knowledge and the experience, to help them do it, versus a PA or somebody else to help do that. But I'd have to take a closer look at, and I know Ann wants to say something. I just know that there are different constructs where if you have a license in some areas, and it's mostly under federal law, that if you don't need the license to do your job, you're not allowed to maintain it or something. I don't see anything and like that. But Ann wanted to say something too, because it's a very complicated area.
So just a few things, like I'm not trying to like muddy the waters, but a few things to like maybe consider as you're discussing this issue. One is that an individual is licensed by the board. And so we do have some jurisdiction over them, right? We look at substantial relationship all the time, right? Criminal convictions is an example maybe of something. So maybe like looking at it, considering it through that lens might be helpful. I don't know, I might be muddying the waters, in which case then I'm apologizing. The other thing is, as we look
To that point, can you explain how we could apply that in this situation?
So I'm throwing things out here, and I'm not an attorney and I'm not a pharmacist. So good luck with that, right?
You're a technician though.
So I think that if someone did something that was a significant departure from their knowledge, skills, and abilities, right? Misuse of education, those kinds of things could potentially be drawn in. So if I'm making something up, right? I'm not talking about a case. I'm totally making something up right now, right? So if a pharmacist is compounding in an unlicensed clinic, right?
Let's make it be a pharmacy technician.
Yeah.
Well, I think that, so.
The
we can-
pharmacist,
we
I
can
kind of
try to-
agree with Maria and Song
I
that
think they're separate.
we have a wider reach with the pharmacist.
So if so it's a little bit harder when it's a technician, right? Because their KSAs are different. right? But I think that if an individual knows that you should never do X, you would never do X. The technician knows that it would never be appropriate, I don't know, to take a pill, pound it, and draw it up into a syringe and give it to someone. If they knew that that would never be appropriate, they are still our licensee. Whether or not we could, I don't know how that investigation looks because we don't have jurisdiction over the prescriber, but we have jurisdiction over the individual that possesses the license.
Right.
And so I don't know that I've explained that very well.
I think we're kind of going a little bit too broad, and it could confuse our discussions. What I was asking to discuss when we would put this agenda item together, and it needs to be broadened a little bit too, is that pharmacy technicians, first of all, cannot practice outside of the oversight of a pharmacist. That's law. The only one is the waiver. No, well, and in a pharmacy. So that's a good point, Ms. Field. It has pharmacy technicians practice under the oversight of a pharmacist and in a licensed pharmacy. The only exception is that current waiver that we have for mass vaccination clinics. But what we do have is people who are trained and licensed as pharmacy technicians working as pharmacy technicians in unlicensed activity. The activity is not wrong. It's the title that's wrong. That they could be doing that activity, but not as a pharmacy technician. They could take their skills and their experience to those functions, but they're not a pharmacy technician working in a doctor's office. That's not legal.
I think the struggle for me is trying to obviously kind of find a solution, and I'm having a hard time figuring out how can we actually solve it if you're not tackling this unlicensed place of business utilizing licensed technician. And like if we're going after technician, then we're not really solving, I guess, and those areas that are maybe not our purview at this point. And I'm just actually thinking bigger picture, maybe we could have those under our purview at some point.
I totally agree with you. I think that we can't eat the whole elephant at once. We have to take it a little bit at a time. And what we do have current jurisdiction over is not being completely managed. So we need to manage what we have current jurisdiction and then look at in the future additional jurisdictions perhaps. I'm sorry.
So I have a question.
Cameron Banks.
My understanding is that you are only a pharmacy technician when you are working in a pharmacy under a pharmacist.
Yes.
So when you are outside of that, you're operating under something else. So I'm just wondering, are we missing in terms of the relevant law under the business profession codes, what is authorizing that individual? Like, I'm assuming we said it's under the medical board. We're missing some definition here that categorizes that type of labor, that type of work.
You're
right?
correct, because it's not under our purview.
So we
I
don't
think
know what
we,
it is.
what we have typically recommended is that the position title and the name tag does not say pharmacy technician. It says medical assistant or whatever is the appropriate medical board term.
So that's what you're saying. The specific concern is that there is, for these examples, where like bullet point 1 and bullet point 2 is that when you say board licensed technician, it means that they are wearing a name tag.
And you're right.
Okay.
And their position title. They could have those skills. I think what is very similar is that we do have physicians who are licensed in other states who are practicing as nurses in the state. They have the skills and the experience, but doesn't mean that they actually wear a name tag that says I'm a physician when they're working as a nurse. They may have a license as a nurse in California, but not as a physician. Is that a similar example?
That's what I was going to bring up. I was about to say I don't want to complicate further, but I feel like there is a huge umbrella law actually with the name tag requirement in their license category. So I think it's BPC
There is, there is a,
once.
there's someplace in the pharmacy law that does say that a pharmacist has to say pharmacist and
No,
a
there-
technician has to say technician.
I think
and a
there
clerk
is-
has to say clerk. That's. Okay.
Sorry, I do agree that there can be some confusion if somebody deals with a pharmacy technician, say when they go to a pharmacy and then they go to in a practitioner's office and then they're having somebody else that's saying a pharmacy technician is doing something and it's like, wait a second, they're outside of the office. Could we try and get through that? The problem becomes the corollary about some of the prohibitions, but I'd have to look at that with respect to that. There's something else we could potentially look at, and that is something with respect to, can people obtain a license if they're just going to use those skills outside of a pharmacy? There are some different things that, that people have done to limit, and it definitely happens under the federal rules, I know, at different points. But with the name tag, I'd have to look at that. It'd be how you hold yourself out. If somebody was a pharmacy tech and had a pharmacist badge, obviously that is false. You're overstating your skills. Obviously, it's lying, it's fraudulent.
I think we're kind of missing the point here. So let's say we solve this and nobody in doctor's offices anymore has a tag that says Debbie Veal, pharmacy technician, says medical. But we still have bad stuff happening. I mean,
Right.
so
I think we have to be
like,
incremental.
who cares?
Yeah.
Let's solve the problem. Let's
Yeah.
not the stupid name tag. I mean,
I do see your point about that. And I think that just for us to move forward is, I'd like to make a suggestion that we also discuss the second part, which is about pharmacists. But the first part, before I make a suggestion, because we don't have time to do a motion at this point, because I don't want to get public comment also, is that this really is an issue about technician licensure. So I think that maybe it should be discussed more at the licensing committee about technician licensure and name tags and all of that. What do you think, Debbie?
well, I think it's actually perfect timing because we're looking at the whole technician thing. So it's actually beautiful timing to try to.
So that little
That
part
piece of it,
to go
yeah.
there.
And I agree with you. Let's go on to bullet point 2 and 3 about the pharmacist compounding.
And then the third issue would be potentially a new agenda item to talk about other practices outside of licensed pharmacies that do compounding in some way. I'm not sure how to word that, but that would be a future agenda item.
And that's something you could probably cover as we start to tackle the proposed changes to the compounding standards under USP, correct? I know there's different points.
Potentially, but I think that we could add it as an agenda.
So you're
item.
worried about people who have like no education compound. I mean, is now a licensee of the board compounding. That's the item, that's the other.
That's what I hear from the members. That was not on the agenda as being discussed today, but I hear from the members that is an area that you want to dive into.
Yeah.
So the second item was really about pharmacists. And because pharmacists, as you are all aware, can practice outside of a licensed pharmacy. What we found is many pharmacists, because of their skills and their experiences, are working in the area of compounding in different practice settings that are not licensed pharmacies, like clinics, infusion centers, doctors' offices, those kinds of things, which is a wonderful thing for patient safety and for consistency, because pharmacists are really proficient and efficient at those functions. The challenges are that the board does not have purview under those practice sites. And so there are pharmacists who have blatantly decided that they're not going to follow all the compounding regulations of the Board of Pharmacy because they're outside of a licensed pharmacy. My understanding is, as a licensed pharmacist, they are still required to follow all of the regulations in and outside of a licensed pharmacy. So that's kind of a blanket. See what the rest of the board thinks or maybe we even have some examples if you wanted some more.
Does our council agree with that?
That's a tricky issue there as well.
Still looking up name
Would
tags?
some,
Outside of the pharmacy practice, they can go outside of pharmacist.
So maybe as a first step for that specifically is at the staff level, we can look at this issue, the larger issue, and see maybe how other jurisdictions are handling this and provide a little more education on the scope of it. The only other thing that I wanted to just quickly throw in is that as we're talking about the standard of care group and they're looking at potentially transitioning more to a more robust standard of care model, I think that that could impact at least pharmacists and how they are performing compounding. But we're also going to need to look at the federal law and what those requirements are for guiding the different kinds of practice settings. And I'm not positioned to do that today, but perhaps some additional education, both at how other states are doing it and what federal law requires in those other jurisdictions may at least be a starting point.
yes, go ahead, Jim.
And if you look at patient safety perspective right now, any of these pharmacists or technicians compounding outside of pharmacy in a doctor's offices, if they made an error, or let's say a product gets out and it significantly harms a consumer, there is an agency, medical board, that's looking into those cases. Do we have any, just, what you mentioned, would they bring it to our attention that there was a pharmacist practicing over here and this error happened, or they want us to take any actions? Has that happened in the past because something significant happened?
So I feel like I need to be kind of careful because what you're asking me is specific to investigations. So I'm going to keep my response extremely high level and keep eye contact with counsel who can't kick me under the table. But I would say, Jig, here's how I'm going to answer your question. And I get that it's not exactly the question that you asked. We have on occasion been contacted by both the FDA as well as local jurisdictions and other regulators about the issue of compounding. And can I keep it at that? And maybe you can connect.
Yeah, I connect the dots.
So I appreciate everyone's patience on this very complex issue. The purpose of discussing it today was really to bring it to the fore for us to decide how to break it apart for further discussion. There really are no action items for us at this point. It was mostly to bring this to public attention, to hear from the public, and then maybe we could come up with some actions after. I'm really leaning towards wanting to hear from the public before we move with what we want to do, because I think we may get some more information from the public if that's okay with the board members. Okay, so let's start with public comment with those in the room in Sacramento.
Thank you, members of the committee. Mark Johnston with CVS Health. You touch on a number of different questions. In this scenario, the technician could just voluntarily surrender their license and there'd be no jurisdiction, and that's an easy solution for somebody who you put the pressure on. So something to consider. Unlicensed personnel don't have a license. And if we're taking the position that a pharmacy tech is not a pharmacy tech outside of the pharmacy because they're not wearing a badge, how about a pharmacy tech who does data entry for a pharmacy? It's not a technician duty. It's a duty of an unlicensed personnel. If they take their badge off, can they now do remote data entry work? Maybe. You mentioned, pharmacist compounding outside of a pharmacy, and that is, allowed by the practice of pharmacy, but yet we have a waiver. Pharmacists can't do remote data entry, but they can compound, and you need a waiver for remote data entry. And if I read what we're waiving, I don't think the law is even talking about data entry. I think they're talking about working for a physician, sending the initial prescription to the pharmacy, not subsequent data entry by the pharmacist. So I think, to Ann's point, when you go to a standard of care model, a lot of this clears up. When you have a law book that's 800 pages, it gets very complicated. And I think you have many situations to address. This is one tiny piece of the remote web that is complicated and quite frankly, a problem in California, I think. Thank you.
Thank you. There are no more public comment at the Sacramento location. We're ready for WebEx.
This is the moderator. I've opened up the Q&A panel in WebEx. On WebEx, locate the Q&A icon, type word comment into the text box, and click send. To utilize the raise hand feature, click on the hand icon next to your name, or for call-in users, dial *3. The instructions are on the screen for your reference. So we do have individual identified as John Gray who would like to make a comment. John, I'm going to send a request to unmute your microphone in just a moment. I am going to set the timer for 2 minutes as well. Request has been sent, John.
Hi, good morning. This is John Gray. I'm a registered pharmacist with Kaiser Permanente. I wasn't expecting to comment this morning because this was agendized related to compounding outside of licensed pharmacy, where we don't really have a horse in that race. But the discussion went into areas other than compounding, and so please forgive me if my comments are a little meandering. I wasn't super prepared to comment on this, but we do encourage the board to work to remove the statutory and regulatory barriers to licensed pharmacy technicians performing non-discretionary tasks under the direct supervision and control of a pharmacist who is working outside of a licensed pharmacy. So, specifically, we're talking about Section 1793 of the California Code of Regulations and Section 4038 of the Business and Professions Code. And we believe that regulation and statute should be amended to remove the reference to pharmacy technicians working exclusively in a pharmacy. As the committee discussed this morning, the board has recognized the value of utilizing licensed pharmacy technicians outside of licensed pharmacies to support the operations of COVID-19 mass vaccination sites. California law obviously allows pharmacists to provide a wide range of healthcare services, both within and outside of a licensed pharmacy, including ordering, interpreting labs, participating in the evaluation and management of health conditions, as well as initiating, adjusting, and discontinuing drug therapy. And the board is certainly aware of the kinds of services that results in: provision of HIV, PEP, and PrEP, travel vaccines, management of anticoagulation medications, any number of other services. And as I'm sure you all can imagine, there are a number of tasks that need to be done in order to provide these healthcare services that do not require the education, experience, training, and specialized knowledge of a pharmacist. And in most cases, pharmacy technicians perform these types of tasks within a licensed pharmacy already. Some examples include
This is the moderator. I've muted the speaker. The 2 minutes were up. There's no additional requests for public comment. Would you like me to close the Q&A feature?
Moderator, I think you did not give a 10-second warning. So maybe Dr. Gray could finish his comments.
Okay, no, I apologize. I did give a 10-second, but perhaps it didn't.
I'm sorry, we didn't hear you. Sorry.
Yes, no, apologize for mine. Maybe it didn't come through. Let me find once more. John, I'm going to send a request to unmute your microphone and
Yeah, thank you so much. I appreciate that, Dr. Serpa. I'll be really quick and just finish it off. Essentially, we believe there are tasks that pharmacy technicians can assist pharmacists with outside of licensed pharmacy space that they're already doing within licensed pharmacy space. So we think that licensed pharmacy technicians ought to be able to function as licensed pharmacy technicians under the direct supervision and control of a pharmacist. outside of licensed pharmacy space to support pharmacists in that manner. But thank you so much for the opportunity to provide comment and for the little bit of extra time to close it out. Thank you.
Thank you, Dr. Gray.
This is the moderator. I have Paige Kelly. I apologize if I mispronounced her last name. Who has her hand up. I will send a request to unmute your microphone.
Thank you, moderator. Paige Talley with the California Council for the Advancement of Pharmacy. I just wanted two things to say. One is I completely agree with the previous speaker, John Gray. And I have some concerns because there are many pharmacies that might have too many pharmacy techs because of the ratio issue in California. And so they make their techs a clerk. And that should be totally acceptable. I know previously Counselor Smiley said I can't ask a question. So I'm just making that comment, but it's kind of a question. Thank you.
Thank you, Ms. Talley.
This is the moderator. No further requests. Would you like me to close the Q&A feature?
Yes, thank you. Board members having some complicated discussion and hearing from the members of the public, do you have any further comments before I make some suggestions of path moving forward? Seeing none, I think some ideas for a motion or for a path moving forward. I don't think we need a motion if we refer it to another committee. I think that the issues regarding pharmacy technician are complex, but related to issues under consideration by the licensing committee already, and would suggest that the discussion continue there in the licensing committee. Board members, what are your thoughts about pharmacy technician discussion continuing under the licensing committee?
I agree. We should send it to the licensing committee. I'll make that motion too.
I don't think we need a motion to refer. No.
Okay.
Thank you. So the issue regarding pharmacists practicing in a non-licensed location and requirements thereof, there's an opportunity to address this under standards of care, or are there any other suggestions? Ms. Smiley or Ms. Sodergren, do you have any other suggestions?
I just wanted to follow up. Is the committee interested in staff doing additional research to see how it's handled at the national level?
Yes,
The larger issue?
if staff could do some.
So let's do both. Let's make sure this issue is addressed with standards of care, but the committee would continue to investigate and determine more information. Is that amenable to the board members? And the third issue regarding unlicensed locations that do compounding by non-board licensed personnel. Ms. Smiley, since that was not agendized, is that something we could talk about, or should it be a future agenda item?
I think we can just put that under a future agenda item when we're dealing with compounding, because some of that would be statutory changes. So let's not discuss it now.
So
It just should go to the next, as part of compounding, I think.
Thank you. Members, those are the suggested actions. Any other comments or concerns regarding this agenda item? Do we need to do any board public comment again, since we had a little bit of discussion?
I don't think so. I think you were just talking about next steps, and it's not something that's a final motion.
Thank you, Ms. Smiley. Do we have number 5? That's 5. Agenda item 6, as a reminder, was deferred and will be discussed at a future meeting. Moving on to agenda item 7. Review and discussion of enforcement statistics. The statistics are included as attachment 3 and a summary of information provided in the chair report. The fiscal year end board had received 2,336 complaints and closed 2,360. The board issued 230 letters of admonishment, 949 citations, referred 120 cases to the Office of the Attorney General. In addition, the board has revoked 44 licenses and accepted 67 disciplinary surrenders. Members, do you have any questions or comments on these statistics or any others that are in the report?
I know some of those are administrative, not just criminal, right? Yeah.
So the board does not have a statute of limitations. Typically, it is an issue of mitigation or aggravation if we pursue discipline. Unfortunately, some of the delay is because we're down a couple of leadership positions in enforcement.
But, yeah, when you said refer to the district attorney.
Yeah, so there is no statute of limitations for cases that are referred to the AG's office through the disciplinary process. And I'm talking in general terms, not specific to this bucket, but in general terms, depending on the duration of time from the date of the violations included in your disciplinary guidelines, as those are some of the considerations when we're looking at the appropriate penalties and outcomes.
I could draw your attention also to the average days of investigation, which is one of the enforcement statistics, the first page. And you could see that most recently, the average days have decreased significantly. So the office is working more diligently to close out investigations more quickly. Any other board comments? Let's open up for public comment. Any comments by members of the public in the Sacramento location? Seeing none, let's go to the WebEx.
This is the moderator. I've opened up the Q&A panel on WebEx. If you would like to comment on WebEx, locate the Q&A icon, type the word comment into the text box and click send. To utilize the hand raise feature, click on the hand icon next to your name, or for calling users, dial *3. So I'm checking to see if there are any hands raised and also any comments. We do not have any requests on WebEx. Would you like me to close the Q&A feature?
Thank you.
Thank you.
Thank you everyone for your time today and your patience with dealing with this new hybrid format. The committee will be meeting again on July 19th. Please also watch for the committee's updates, as we're hoping to have an additional meeting in August to discuss compounding specifically. The meeting is adjourned. Thank you.
Thank you.